On behalf of the RSNA, thank you so much for joining us. RSNA also wants to thank Zebra Medical Vision for sponsoring this webinar that we're having today and this panel. My name is Matt Lungren, and I'll be your moderator and host for today's session. This webinar is one of the many ways RSNA is trying to reach out to the radiology community broadly and to try to provide more education and other resources and get you in contact with some of the leading experts in certain fields, in this case, AI and radiology. And today's webinar will be recorded and will also be freely available on RSNA's YouTube page. So if you do miss something, you can always come back and check it out later. With us today, I'm really excited to have such an awesome panel today. We have, starting out, we have Dr. Felipe Kitamura, we have Dr. Carol Wu, we have Dr. Judy Gichoya and Dr. Orit Wimpfheimer. And before I sort of go through and introduce each of the speakers, there are a few housekeeping items I'm just going to cover really quickly before we formally kick off here. Let's start out with this disclaimer. This is the general disclaimer statement. I'll give you just a sec to read it. It's like those Apple things, you just kind of click accept. So just, we'll just bear with me here. The next thing after the disclaimer, I'm sure you've all read that thoroughly, is that you get to ask questions. That's really the cool part about this experience. We're going to have an opportunity to engage with all of you who are joining us right now. And so you'll have an opportunity via the question panel on your screen to submit your questions during the webinar. I will do my absolute best to monitor that sidebar as we're having the discussion to make sure that I can get your questions addressed or try to pool them together and field them to the panel as we have our discussion. All right, so let's introduce our speakers. I'm sure most of these faces and names are familiar to you, but we'll start out again with Felipe Kitamura, who is the head of AI at DASA. He's a neuroradiologist and also a PhD candidate in the Department of Diagnostic Imaging at the University of Federal down Sao Paulo, or UNIFESP. Sorry, that's a very difficult acronym to try to blend together. He's also the in-training deputy editor for the Radiology Journal and co-chair for the ML Education Subcommittee at SIM. So welcome, Felipe. Next, we have Carol Wu, who is a thoracic radiologist at MD Anderson Cancer Center and the chair of the Big Data Committee for the Society of Thoracic Radiology. She serves on the RSNA Machine Learning Data Standards Subcommittees and the ACR Informatics Commission. So welcome, Carol. Next up is Judy Gichoya, who needs no introduction. She's a multidisciplinary researcher trained as an informatician and a clinically active radiologist. She's an interventional radiologist at Emory. She's been funded through Grand Challenges Canada and the NSF ECCS. Her career is basically focusing on validating machine learning models for health in real clinical settings, exploring explainability, fairness, and with a specific focus on how algorithms can fail. She's worked on the curation of data sets for SIM, the hackathons there, and the ML committees, so she's very familiar with this space. And she's currently working, as you'll hear a little bit about here at the beginning, some of the socio-technical context for AI explainability for radiology, especially the dimensions of the human factors that govern our perceptions and preferences for user interaction. And last but not least, Orit Wimpfheimer. Dr. Orit Wimpfheimer serves as the clinical director at Zebra Medical Vision, where she joined to help with her clinical perspective in creating algorithms for radiology. In that practice, she actually came from a strong radiology background. She founded a teleradiology company that served hospitals in the US for 20 years and holds a BA from Barnard College and an MD from Albert Einstein College of Medicine. So welcome, Orit, great to have you here. And then finally, it's me, I guess. I'm Matt Lungren. I'm the co-director of the Stanford Center for Artificial Intelligence and Medicine Imaging. I'm an associate professor at Stanford, and my work is focused on AI and medical imaging, but also across both pixel and non-pixel data, as well as patient predictive outcomes. So really glad to be here with all of you today. Thanks for joining us. And before I turn it over to Judy, I do want to mention that, again, we'd like to kind of interact with all of you out there as sort of the audience participation component of this. So there are going to be some polling questions that we'd like to kind of use to get to know our audience, what kind of breakdown of backgrounds and demographics we have out there. So we'll have a couple questions for you guys before we kick off the early portion of this didactic session. So let's get those polling questions rolling. And hopefully all of you are able to see those questions, and feel free to just start clicking your answer in. And just for those of you who may not be accessing the polling questions now, so you're not in the dark on this, the first question is, are you currently using AI as a diagnostic tool in your practice? And the second question is your institution currently involved in developing AI algorithms for radiology? So you'll see both those questions one after the other. And so please click in your answers and we'll give you a couple minutes to fill those out. And while you're doing that, I'm just going to kind of give a brief background as to how today's going to generally flow. We're going to start out with an overall overview of AI in COVID-related imaging, just sort of to set the stage. We've found that as many of you are obviously experiencing, this current pandemic has certainly been a catalyst for a lot of conversations around how we can better use technology and data to impact healthcare. And certainly this has become a very critical use case that has focused in a lot of ways on imaging. And so Dr. Gichoya will sort of kick this off by setting the stage with all the things that are up to date, at least, that are going on with COVID and AI, and particularly in imaging. And then we'll use that as a launching pad to sort of discuss more broad areas as we go along. All right, so I am receiving most of the answers here from the group. It looks like with 71 or so answering at this point for the first question, are you currently using AI as a diagnostic tool in your practice? It's about 63 to 37 that are not sort of using AI, at least currently, versus the 37% that are. So that's a very interesting breakdown. I'd love to have you all out there asking questions about that as we go. And then the second question, is your institution currently involved in developing algorithms? It's about a 60-40 split. We're seeing 60% yes, 40% no. So it's almost, well, it's almost a reverse here. So it's very interesting. People are developing them, but not necessarily using them in their practice yet, which is a really great way to set the stage for what we're going to talk about today. So this is terrific, terrific group. All right. With that, I think I'm going to turn this over to Dr. Gichoya to start with her overview. And Judy, you have the stage.
Thanks, Matt. When I was thinking about this, especially because I only have maybe 10 minutes to speak, I would have said digital transformation through a pandemic. This is the title, the real message of this talk. And like Dr. Lungren said, 2020 requires no introduction. I mean, I am counting down to the end of the year. This is the picture from Hopkins site that tracks COVID, over 1 million deaths with over 44 million cases. And as we know, if you've been watching the news right now, we're going through, I guess we always call it another surge, but quite a number of cases. And what's not changed really, at least we've not made a difference. I really like this picture taken in a wall in Kibera, which is one of the slums in Kenya. And Kenya is home. And I like this mirror because it talks about things that you didn't even need to read. It's this unified message, right? No crowds, the social distancing, washing hands and, hygiene and masking, And I think what drew me to this is that, it's this focus that the COVID-5 is really requires the community approach because, as you know, that it's been a little difficult to move things forward alone. And we've seen some of those sort of efforts, both from the government and private and public partnerships. And so we are moving to what appears, at least in our minds, at least in my mind, to what appears to be the new normal, where sometimes we have to close, we have to think about capacities in the hospitals. But what's also happened really is that we have, learned how to lower the barrier for this digital transformation. So if you had ever told me 1 year ago that we'll be using Zoom for telehealth clinics, I mean, that would have been out of the world to think about. And if you even said that I would be reusing my mask, that would have been, I would have been punished because that's not what is expected in the healthcare. So it's this new normal. And we know that some things that it's always a learning day for the healthcare system. One of the things that we know is that I don't know that everyone is going to shut down completely, especially because of financial implications. And so how do you sort of innovate and how do you provide care in this new normal? And so when we started off with this pandemic, we actually wrote an opinion paper as part of the RSNA AI journal. This is one of our trainee editorial board members, Shinjini. And we were asking, how would AI and chest imaging help unravel COVID-19, mysteries? At that point, really the debate was, should you use imaging versus RT-PCR test? And quite a couple of societies came out and said it shouldn't be used as a screening tool. And could you start to use imaging to provide a disease trajectory, for example, the corona score? And we've seen quite some work done with this, including a federated learning example using the ACR AI lab. And then could you start to get imaging correlates for severity? And when we got to a drug, I know we're still in the process of evaluating a vaccine, could you start to have personalized treatment choices that would have correlating imaging markers? But still, in my opinion, we're still here where there's still the magic. This has been my life for the last couple of months, where I get scanned every time I go to the hospital and I get a sticker on my badge. And, I think still screening and contact tracing, we're still back on that basic block, because we know quite a bit of some patients, most patients are asymptomatic. And so how does isolation and cohorting work? And when we say, AI can see things that we are blinded to, I think we saw quite a bit of big companies, Google and Apple, come even together, aside from their business competition, to think of what contact tracing would look like. And so we are struggling with figuring out screening. Then we have to think about resource allocation. And that's because if you have a few ICUs, then you're going to get into trouble. And also that realizing that this pandemic also has an even bigger pandemic on minority patients who have almost a double tragedy. And so who are losing their job, but also the disease are disproportionately affected by the disease. And so, every time I see this, I'm like, what would the killer app be? We'll hear what Dr. Lungren says in the era of COVID. And so when we started out, these were two models that were actually very, very used. This is some of the work we started to see earlier, focusing on chest x-rays, of course. And one of the things I like to remind people here is that sometimes imaging, and this is the things of AI, is that you find that when you're imaging patients, it's not just the imaging that we do AI on. We also do AI on previous, we have to think about the people who are acquiring the images. So you may have the best AI system, but if everyone is afraid of providing care or going to get the images, then your AI cannot work. And so these are two models using deep neural networks that were trained, some of the earliest ones. And so what we did, we took some of our earliest chest x-rays and we didn't label them any differently. I just used the RT-PCR test results as ground truth, and then just tested how these models work. And so you can see with one of them, same data set, picks 1255 COVID positive patients, and the same data set, it says these are negative. And so this starts to be troublesome, because when you look at sort of the reported percentages and like accuracies, when it comes to real life clinical use, then you start to really get into the things that we've always known. It's hard to work in this space. And so we went a step further and picked these three data sets, which we know at the point we did not have COVID-19 when these data sets were created. Now, if they have been updated, that's different, but at this point they did not. And we had race information in our data set. And we start to see what will be the performance of these models on these data sets. And we see quite a high false positive rate within our own data set and a high false negative rate within our own data set. The false positive rate is seen on the checked expert and the mimic data set. And so You know, when I think of this and I think about my work, you know, when I started this pandemic, working in this pandemic, we had extreme, this is my bag, I still have it, thankfully with new N95 mask. We knew sort of what were we dealing with under testing of false negatives, how are we dealing with resource utilization, and also just truly the fear, stress, and burnout of working through COVID, and how are we sort of changing our own workflows, you know, either in terms of staffing, or which came up remote staffing, or you know, cohorting teams, so that if one person was sick, you'd have contact tracing. And so these are the sort of like some of the things that are and at least were going on through our minds. And so when I started to see this, I started saying, well, if Africa, we can have drones that actually select the weeds, why couldn't I have better equipment to clean my room and be assured that the rooms were clean after the patients were in there? And so what did these AI systems have an impact on my workflow, and what was the role of robotics? And so we went back and still, like, I find our team really likes to work on the sidelines of sort of supporting the big ecosystem. And so this is a multi-reader study that we've just completed with 10 radiologists from 3 institutions, and trying to see, okay, beyond the RT-PCR, what are the visual characteristics of the imaging that we have, and what does that mean? And you can imagine even this has nothing to do with AI, because Carol Wu, who is very excellent at reading chest x-rays, I'm losing my skill at that. And so what does ED performance, who would be sort of reading screening radiographs, look like? We started looking at beyond imaging, so we used natural language processing to predict ICU transfer for hospitalized COVID-19 patients. And you can see, just looking, we can figure out who's, just from the notes, who highest risk for ICU transfer before the actual transfer. Well, I said there's a lot of funding that has been injected in this and advancing AI, and part of the NBIB funding, what we're building is multimodal fusion models that merge demographics, prescription, coding systems, ICT and CPT, and labs, and then start to figure out how do you start to use those for patient cohorting and triage. And, you know, just a change in tone really is that even other people are starting to build AI systems. I know EPIC, the EHR system, has been working to predict which patients will become critically ill. And what I want to say is that, you know, some of these tools will come to the marketplace, and in our workflow, you know, sort of as hidden, become just as a decision support, or just, and that brings, I think, a bigger challenge, especially when we're already adding another layer of a black box to black box algorithms. And we still see the same things, quite a bit of FDA, you know, approval. And this is something that was granted approval in May by the FDA. And if you look at the algorithm, we see a precision of less than 5% for respiratory failure, and with a lead time of 4 hours. And so better for hypotension at 16.5% with the same lead-in time. So, you know, how would you sort of utilize what's the clinical utility of such an algorithm? Now, to my last slides here, in the era of rationing, some people don't like when I say that, but really sometimes we have to decide who gets the treatment and who doesn't. And so this is some work, it's being peer reviewed right now, where we looked with a group from MIT, where we've looked at scoring system. There are 3 Apache, SOFA, and OASIS, and we look at the ESU and the MIMIC data set, and we see that there's no discrimination when it comes to race, in terms of, if you have a high score, you're probably pretty sick across both data sets. But there is actually a poor calibration for the races, you know, so Hispanics and African Americans, you know, have an estimated higher mortality more than actual mortality. So higher predicted mortality more than actual mortality. And this is challenging because if you had 1 ICU bed or 1 ventilator, you want to give this to the person who's most likely going to survive. And so as we start to introduce AI systems in the clinical workflow, we have these ubiquitous scoring systems that still guide our decision making, and much as the potential is there for AI, we have to proceed with caution. And so in conclusion, I think through these few months, we've seen quite a lower barrier of entry of introduction of digital tools. We've seen what, beyond what we would call AI, which is, like especially the rise and adoption of telemedicine and home care. We've seen some reimbursement changes that may be coincidental with this AI and CMS. But I do anticipate that we'll see quite an appetite for funding these efforts. We've seen lots of data efforts funded by the NIH and also institutions, and some also moving into the open source. And so, and then, we haven't seen much in sort of like the context of AI deployment. And I think this is where we will figure out how useful these tools are. And again, this is 2020. We have to remember the humans and the people who are working as we move forward. I would like to thank my team here at Emory. This is our lab, and back to Dr. Lungren.
Thank you so much, Judy. That was terrific. And, it's still hard to believe, that this is, I mean, as you said so well, the new normal. This is here, this is happening. And, and what you were able to sort of cover in such a concise way is really the fact that, we've been dealing with this only for, a few months, right? February, March is when we really started working as a healthcare community on this problem. And yet you've already shown us, and there have been, so many different research projects on every aspect of sort of the AI ecosystem throughout healthcare, right? Going from development to bias to deployment, sort of, and implementation, and sort of thinking about how these tools and technologies are going to affect our practice. And the accelerated timeline, I think, is just it's fascinating. In some ways, it's hopeful. It's giving us a lot more insights than maybe we would have gotten otherwise. But at the same time, it's certainly, as you referenced, the black box and the potential for harm and bias, something that we need to pay close attention to. So thank you. So at this point, we're going to open it up for all of you. So please feel free to answer some questions of the panelists. I have a few questions that I'll kick off with, and then we'll kind of get everyone in the mix. I think starting out, I wanted to ask Dr. Kitamura a question about sort of jumping off from what Judy sort of kicked us off with. I mean, do you agree, or do you find that COVID really did, this global pandemic, did it really accelerate the need, the interest in applications of AI in healthcare? And is this something that you think will have an effect on other use cases as we go forward?
Just unmute myself. First of all, I wanted to thank RSNA for inviting me to this webinar. It's a pleasure to talk to you all here today. I think it's weird to talk about benefits when we see so many people being negatively affected by COVID. But the truth is, we have also seen many examples of people all around the world leveraging AI to improve patient care for COVID patients. We all know AI needs a lot of curated data with high quality annotations. So first, I wanted to give a shout out to this project called RECORD, led by Dr. Lungren, who's moderating the session today. So RECORD stands for RSNA International COVID-19 Open Radiology Database. This initiative will foster the development of AI tools for COVID by providing a large data set of curated images from many different institutions in many countries, also annotated by experts from the Society of Thoracic Radiology, represented here today by Dr. Wu. I'm telling you all this because data is essential to create these kinds of AI tools. A use case I wanted to mention is the lung segmentation on CT chest. We developed a model at DASA that quantifies the total lung volume and the percentage of consolidation, ground glass opacity, and normal parenchyma. We also showed that this quantification, along with clinical and laboratory data, was a strong predictor for survival and also for the need for ICU bed. And after validating this tool, we deployed it in our packs, and radiologists found it very helpful to have the automatic quantification at the time they were actually reading the scans. When reviewing our COVID cases, our chief thoracic radiologist, Dr. Rogério Pinetti, he noticed the general radiologists were quite good in quantifying less than 25% and also more than 75% of lung damage, the extreme cases. But the variability between 25 and 75% was higher than we wanted. So this is where we expect the AI model would be useful. This is just one example of the work we did at DASA. I know you and many of you may already heard of many other sites doing similar initiatives. I've heard UC, Irvine, Stanford, us at UNIFESP as well are doing similar things. Another interesting use case I'd like to mention is the exam project led by Mona Flores at NVIDIA. So this was a federated learning approach to develop an AI model to predict the need of oxygen therapy from X-rays and clinical data. A total of 20 centers in Asia, Europe, North and South America, including DASA, participated in this development. And it was interesting to see how the global federated model generalized better than each model trained locally on each data at each institution. We've also seen many companies also creating AI models to triage patients with COVID in both X-rays and CT scans. And this has, I think this may have had a great impact in some hospitals, especially in the setting where PCR was not available in the beginning of the pandemic. And AI is not only applied to medical imaging. There are many ways we can leverage AI to find patterns in data from other sources like clinical data and blood tests. For those of you interested in this topic, I highly recommend the Radiology AI editorial that Dr. Gichoya just mentioned, whose title is How Might AI and Chest Imaging Help Unravel COVID-19's Mysteries? So this is mostly what I think in terms of the benefit it may have had in some places and the experience with that. In terms of COVID accelerating the need or the applications of AI, as you asked, Dr. Lungren, I'll describe also what happened to us at DASA as an example, but I've seen the same pattern happening in other institutions all over the world. Back in March this year, when COVID was declared a pandemic, a lot of non-essential services started to shut down, including outpatient care. This happened here in Brazil as well. There was a 90% drop in the number of exams performed in most of the clinics, leading to a massive and transitory availability of radiologists. I guess we were all trying to figure it out and looking for ways we could help out in that scenario. Meanwhile, part of our AI team started to stand idle because most of our job was to deploy and monitor the clinical validation of a dozen other models that were just not being used because of the sharp drop in the number of studies performed. So it was a natural call to focus on those specialized people, focus all those specialized people in a single effort to try to help with COVID. We had 13 full-time radiologists annotating data sets. The data science and the IT teams stopped juggling around with many other projects and focused on this COVID segmentation and prognostication model. When managing several projects simultaneously, we used to take a year and a half, give or take, to complete the end-to-end process from data to validation, deployment, and monitoring. In this case specifically, it took less than 3 months. So in short, COVID did accelerate the development of AI models in our case, and we've seen similar patterns happen all over the world as well.
Yeah, thank you. That's a terrific answer, and I do think it's a comprehensive sort of look at the international efforts that you pointed out. I think again maybe wouldn't have happened as sort of you're illustrating without a call to action. And this, I don't really know of many other calls to action that I think can, galvanize the community as this has. And part of that is, as you've suggested as well, the institutional groups working together, trying to pull together resources. But I think, taking a step back, thinking about this, Dr. Wu, as we all work together, and institutions, industry, trying to find opportunities to really address this crisis with our point of view of the world, which is obviously based in imaging. We saw from Judy's presentation that there could be potential for generalization issues, right, around certain marginalized populations potentially, or depending on the training data, where these tools will be ultimately useful. Do you feel as though there is a broader need to address generalizability, or are there opportunities to really think about how to do that, as specifically as we look at right now models for COVID, at least in the context of this discussion, but in general, how do we get to a place where we can, what are some of the best practices, I should say, to sort of look at how we can ensure our models are generalizable and are doing what they say they can do in new populations?
I think that the performance of AI is very dependent on the training data or the training data set. And this is something that we know, so that we have to pay attention when we're developing algorithms or models to make sure that we have a representative model, perhaps from different location and from different scanner type, different sets of protocol. So I know, for example, when we put together our data set for RSNA challenges, we do make an effort to bring in data from different sources, so to represent different kind of varieties or disease incidence or prevalence in the background. This is something to think about, but then we also have to think about how well the model would work in a specific location. For example, if we're talking about COVID, a prediction model for COVID may work very well in New York City in March or April, but if you bring it to MD Anderson Cancer Center at that specific time, it probably will have very low positive predictive value, just because the prevalence of disease or of COVID was very low in Houston at that time. And we know even with our clinical reports, we use our RSNA classification system. So at MD Anderson, based on our internal data, we know that even at the peak of COVID prevalence in Houston, cases that we would classify as having classic COVID CT appearance, only 50% of those patients turn out to actually have COVID. So it is very hard to, I think, for some instances, for the model to really generalize and still work well in a particular setting. So we just have to be aware and take that into consideration. To some extent, we have to probably fine-tune models in order for it to work well, for example, at Stanford or at MD Anderson, based on the type of patients that we have. But it's good that people are thinking about the issue of generalization. And then when we talk about, for example, quantification of pulmonary opacities to predict prognosis for COVID, I think that is something that could potentially generalize well, that will work in different COVID patients from different places. But then again, we have to think about specific instances where it may not work. For example, we have a lot of patients who have radiation pneumonitis or drug reaction in the lung, and those also present as pulmonary opacities. So then how would that change the prediction or prognosis of these patients? So it's a lot to think about, but I'm glad that we are having more and more of those discussions in general.
Yeah, and you brought up a couple great points there. I think that, you know, data obviously becomes critical, and I think both you and Dr. Kitamura sort of outlined that. And then, you know, sort of the application component ends up being tricky, right? So, I mean, we're talking about implementing a model that perhaps wasn't necessarily trained on the same prevalence of data. Maybe the metrics weren't created on sort of the population that you're planning on deploying it in. And even if it does perform well at first, what's to say that that prevalence isn't going to change, right? So if you had implemented something, you know, using this use case in December of 2019 for pneumonia, for example, how would that have affected sort of as the prevalence of chest opacities change and even a new disease pops up? So it does present some very interesting challenges, and it raises some points. And I think when we had the audience poll, we saw that, you know, at least in this group who, you know, participating in this session, a lot of folks the majority of them are developing these tools, but the minority of them are actually using them in practice. And so I'm sensing that there is, you know, and again, this isn't a COVID specific thing, but I'm sensing that the implementation science is starting to become one of the most important components of all of the work that we all do. Dr. Wimpfheimer, I'm gonna ask you this question. I think that, you know, taking a step back or just sort of looking at the bigger picture, you probably have, coming from the Zebra side, the industry side, the most experience in thinking about broader implementation, in particular across different sites, from a product perspective as well. How do, you know, what are the best practices, and how do we think about, or how do you think about the path forward for successfully translating these models into clinics in order for them to benefit patients? And again, also thinking about the concept of, you know, these use cases, as we mentioned, where you may have shifts in prevalence or even new diseases that may pop up that affect some of the work that you're doing.
Thank you, Matt. I'd like to address all those points, but one at a time. I think as the AI community matures, it's still in its pretty early stages, and COVID definitely has accelerated all the talk around AI, the research around AI, creating products around AI centered on COVID, but there are many other use cases for AI as well. The successful implementation of AI is only going to happen if we really focus on several key factors. The first, everyone can make an algorithm. There are many, many people, research centers, individuals, as long as you have data. And the key is to really have a very wide, diverse data from several different sources that really have a good representation of the patient population and not just any specific area. Here at Zebra, we use data from Intermountain Healthcare, which is a big hospital center out in Utah. We have data from the biggest HMO in Israel, the Healthcare, and we have a very diverse population here in Israel, where Jews have returned to Israel after many years from all over the world. So we have a diverse population, and we have data from India as well. So we try to incorporate lots of different data sources so we can generalize in the population. But the key to really doing AI in a good product way is keeping the patient at the center of the discussion. How are we helping patients? What is our AI going to do to really benefit a patient? And only once we keep that in mind and understand the patients in the different clinical scenarios and what we can do to help, then we'll really be on the right track. And how do we do that? So I mentioned already the diverse patient population and the data sets that we use. You also have to understand the prevalence of a particular disease in that location. So each of our algorithms would have sensitivities, specificities, and then again, predictive values based on different prevalences depending on that particular area, that particular country, state, and medical clinic of different sorts. And the way we do that is we have a large run in the wild set. We run our algorithms on a very large set of data. We create a lot of metrics, sensitivities, specificities, and predictive value based on different prevalences. And we also have different thresholds of our algorithms, so that in some institutions, certain thresholds would be more applicable to create a better sensitivity, and in other institutions, a different threshold might be better applied. And so we try to do all these different things together to maximize our products and our algorithms in particular hospitals. And we are always listening for feedback from our customers. And so if a particular algorithm is causing false positives in a particular area, we research why that is, where it's coming from, and then try to fine tune the product to better meet the needs of the clinicians in that area. So I think that there are multiple factors that we kind of bring together to try to maximize our AI tools in different centers in order to create products people are satisfied with.
Yeah, thank you. And I think that does raise a terrific point. I mean, you talked about sort of needing to do an institution-specific thresholding, right? You're needing to decide based on some of the demographics and prevalence of disease in different areas. This question is probably for anyone to sort of think about, and answer here, and then we'll get to some questions in the chat. What kind of testing do we need to be doing? Is it just a one-time test set in a population or a new instance at a new hospital, and then we're good to go? Or, I mean, how can we imagine that we evaluate these tools on an ongoing basis, or is that even necessary? I'm curious to hear what everyone thinks, because, I sort of feel as though if I had, in using COVID as a use case again here, if I had a model that predicted mortality and outcomes that I developed on data from February and March, and then I did the same thing and applied it to data, now with the changes in therapies, our understandings of the disease, I'm not really sure I'd want to use that older algorithm, right? Because again, I feel like we'd be freezing in time the therapeutic choices that we made when that data was created. And that kind of ties into sort of how we think about the changing landscape that these models will ultimately encounter, because as we know, medicine is a moving target, is not a static system. What do you guys think about that? And how do we imagine, let's say, a trained model? How do we monitor it? How do we ensure that it continues to work? What are some of the things that we need to be thinking about as we're starting to enter this implementation phase, and in COVID, but other places as well?
So can I address that just for a moment? I think that COVID is a very specific pandemic-related issue. Obviously, things are in flux and changing all the time, and will continue to do so probably for the next few years. So it's a very extreme example of the prevalence changing literally week by week or month by month in every different county. So that, I agree, is a very, very challenging situation. And I agree with you. I would not want to use the model of predicting back in March in a location now in October, November. But there are other disease processes that have a more flat behavior throughout the world. If you're dealing with things like population health, which is a feature of Zebra that we particularly see value in artificial imaging, then we can screen population on CT scans, like chest and abdominal CT scans performed for a myriad of causes, identify chronic conditions that patients don't even know they have, such as osteoporosis or vertebral body compression fractures, such as cardiovascular disease, things that often tend to be neglected in reports because that's not the reason the patient came into the emergency room or to the hospital, and highlight those findings in order to identify patients with chronic diseases they don't even know they had. And those diseases don't really change so much over time. They change slowly over time, but not so dramatically the way COVID is. And so if we can use those models more simply and not have to change them all the time, and identify these kind of patients that have chronic diseases for care and try to prevent the future hip fracture or the future MI by doing so. So those types of situations, you don't need to go back to your algorithm and change them quite so frequently. But you're right, the COVID pandemic is the opposite extreme example where everything is really in flux right now, and any model that's created will have to be adjusted over time.
Yeah, anybody else have any thoughts about, sort of different use cases and maybe how they differ? Obviously, with a rapidly advancing pandemic, it's a very easy to draw that example out. I went to college in the Big Ten country, for those of you who know the Midwest football, and on football, Saturday, the prevalence of patients in the ED, and in fact, the whole city, changes drastically from an average age of, let's say, 55 in the ED to down to maybe 25 or 30. Then all the diseases change for just that day because the population in town there to see the game changes. So I do think that there are use cases no matter what you're looking at, not necessarily just COVID. What does everyone think? I mean, are we going to be able to keep up with patterns and demographic changes as we look at different use cases for these AI tools? And are there best practices for this yet? Or are we still all trying to figure this out?
I think there are a lot of different applications or use cases that have things in common. For example, I think even though COVID pneumonia is a new and changing entity, but we've had to deal with pneumonia in general for a long time. And I think some of the quantification tools that we're using for COVID right now would be useful still in the future with other types of pneumonia. And we've talked a lot about detection or segmentation, but I think in general, COVID epidemic has also heightened our awareness of our needs for other analytics or better analytics tools for other parts of radiology. Mm-hmm. So it'd be nice to predict patient no-show, to be able to quickly reschedule patients, or some of the tools for decreasing the scanning time for MRI or PET. I think those applications are always going to be helpful to increase our efficiency, and also, in the case of COVID, to decrease the amount of time that patients spend in our imaging clinic or hospital, so to decrease perhaps transmission of infection. So I think a lot of tools are going to be useful in the future and can be applied.
So in terms of the model reliability that you just mentioned and the use case you implied, I totally agree with Dr. Wimpfheimer and also with you, Matt. What we're trying to do at DASA is we know that there's a very low chance that a model will keep its performance high over time. So we expect some kind of degradation over time. So we are creating these kinds of triggers to reevaluate or retrain the model. So once in a while, we may want to reevaluate a model like once in a year, or depending on the use case, once every 3 months. Also, if we know we bought a new scanner, we also may want to reevaluate the images from that specific scanner. So we're trying to come up with these kinds of triggers that may make us want to reevaluate the models, because we're pretty sure it's not going to keep as the same high performance as in the beginning.
Yeah, so these triggers, right? So I mean, in a regular radiology workflow in most practices, you have an entire group that's specifically focused on ensuring the daily performance of the machines that we use, right? Making sure that all the phantoms are scanned and all the parameters are appropriate for the practice. Is that maybe something that you consider with some of these models, or and then the idea of what's going to be the threshold for retraining? To a question in the audience that's sort of relevant here from Davi, and talking about the fact that training models is expensive, especially when you're talking about large models, and they're going to get obviously larger and potentially more complicated, requiring data set collection, curation, annotation, right, troubleshooting, GPU resources. Maybe for Judy and Felipe specifically here, I mean, is there a way that we can get to a place where we aren't having to retrain and continually fine tune? Are there other options? I know that you mentioned federated learning, Judy, in your talk, but I'm just trying to get a sense of, are we going to be expecting everyone to have to constantly monitor and potentially retrain models in practice? And is that even feasible? And who does that? Who can afford that when these things are so expensive?
My opinion is that I still think we're pretty early in this AI run, right? The one thing that we've seen that's changed is if you think about imaging 1.0, 2.0, 3.0, or this digital pathway for radiologists, we used to, we came from having very poorly pixelated imaging to good imaging, And so now it's looking at this value chain and seeing where we've gotten. But always what we focused on, and if you look at some of the work that was done for someone like by Elizabeth Krupinski, was radiologist performance, right? But that's not the focus now of AI. I think it's efficiency while maintaining your performance, And so if you start to align that what you're going to say, for example, if you think about the value add of something like this AI, is saying that you're bringing efficiency, you're bringing patients early to hospital, I think it's very difficult to take them the challenge of generalizability. In fact, I think people are starting to, there's a paper by Leo, The Myth of Generalizability, and starting to say, maybe you should overfit on your own institutional data if you know where it works best and where it doesn't work best. And so when it comes to this transfer learning, which is how we would reduce the amount of effort required to train, I think we're starting to see some of the audits show differences in performance, right? And I think most of the engineers now are saying that, well, it turns out a cut is not a breast cancer lesion, right? The cut is fitting the whole image. The breast lesion is very small. And if you start to use some of these techniques that are, hyperparameters, for example, with loss of focal loss, which drop some of the pixels to improve generalizability, then you can drop the pixels that would have told you that this is a calcification or something else or a breast mass. And so, and even if you look at sort of like, when we talk about transfer learning, then you have to talk about ImageNet, especially for computer vision. Then you start to see the papers now that they're showing that the labels age. And if you look at some of the newer architectures in 2020, the performance is dropping with the old labels. And now there's need to relabel data. So I don't think, even if we're saying, well, the change is not as rapid, we know as physicians that there's so many subtle things that happen. There's a reason why I do only my GI bleeds at night. And so, or nephrostomy tubes at specific hours of the day, and there are these subtle social things that, I don't know that one person can say they'll conquer. We just have to have these people who audit, and they'll have to get new skills to be able to understand why things are working that way. And so I think some of those lessons will come from overfitting on your own data. Now, I will have to say that we can't also, people are starting to show that maybe when we use traditional machine learning models that are not very resource heavy, especially when you're not primarily doing pixel imaging, that you still get the same performance and you have explainability. So I still think that this space is still, my opinion is that it's still early. There's still quite a bit we don't know about. Maybe the private companies know because, they're more, doing more R&D, but for people like me and you who talk all the time, I still think this space is pretty early.
Yeah, I think we'd probably all agree there. And again, I think this is kind of brought out a lot of the things you mentioned. I will say that you brought up a couple points, and this actually ties back into your presentation as well. If we're relying solely on pixel data, we're only going to get so far, right? Because we all know that even the new radiologist intern, residents recognizes that they need to know about what's going on with the patient before they can really make an informed answer about what's happening on those in that pixelated image, right? What is happening? What's my differential going to look like depending on the context? You mentioned data fusion, which is sort of an opportunity to bring in a lot of the clinical data with the pixel data and sort of concatenate it in a way that allows us to take in that context potentially, maybe make our models either more generalizable, more accurate, or both. Do you feel as though, and this is for all of you, if we continue to sort of broaden our horizons towards looking beyond the pixel data alone, is that really the next stage of the work that we're all doing? Or do you think that it's still going to require us to continue to perfect the pixel level work that we're all focused on?
Well, I could tell you the perspective from industry. I think that in the future, we will need to be connected to the EMR. We will need to have that information coming from the clinical side and incorporated with the algorithms. I don't think we're there yet. I think that is the future goal. I think everyone realizes that any radiologist, as you said, realizes the importance of combining clinical data with the actual images. And I think that our algorithms will perform much better if they have that added advantage as well. And then furthermore, if you can add additional information of how the patient did in the future and be able to then predict what will happen with this type of appendicitis or with that type of diverticulitis. And so then if you create, more information on this particular study for that patient with predictive models based on prior data, I think that's going to be tremendous and a tremendous added value to the medical system at large. I do think that AI is in its early stages and we're not quite there yet, but I do believe that that is the future.
You should tell us about the multimodal fusion. You just published a paper on this, right?
Exactly. Yeah.
Well, I'm not bringing it up for that purpose, but I will say that, you know, well, sure. But I think that we have found that in the non-medical space, in the computer science space at large, multimodal data fusion, of course, as you would, you know, logically conclude in complex problems, does improve performance. I think what still remains to be seen in the medical space is, do we have enough, you know, data that can actually serve as, you know, the other modality. Pixel data is so incredibly rich, and you know, our EHR data is not only flawed but also very sparse in many cases, right? And tends to really push towards patients that are sicker and have more contact with the healthcare system, which can bias our systems in certain ways. But you know, again, this is why, you know, I'm pointing out to you guys. I mean, is that the key to generalizability? Is that the key to you know, those groups that maybe aren't in a position where they can develop a model to, you know, overfit on their own populations? Is this an opportunity maybe for us to develop algorithms that work elsewhere? And so, you know, I think in our work, we had found that in the, you know, in the outside of medicine, but certainly in the terms of the paper, focusing on the medical space, you invariably get some improvement in performance. It's obviously dependent on the use case. But it almost intuitively makes sense that if you have any clinical information that's relevant to the problem, it can aid in the pixel level diagnoses.
Yeah, I do agree that fusing clinical and imaging information will be beneficial in terms of having higher performance in AI models. But I don't quite think it's going to solve or at least help with the issue of generalizability, because as we see differences in imaging protocols, there are also differences in clinical protocols, and these are related to workflow and other things. So I think this may introduce an even harder issue to solve in terms of generalizability.
Yeah, that's a good point. And what do you all think? And there was a question in the chat about taking even a further step back, looking at the global population. You know, how do we develop these tools and technologies to potentially have an application in low resource settings, you know, in sort of a global health point of view? This question is coming from Ivan Canardi from the chat. What do you all think about this? I'd be curious to hear what you guys think about our applications of these tools and technologies in a global health perspective, and recognizing that's a big term, but just trying to imagine outside of sort of the systems that you currently work in, where else could these technologies be applicable?
Quite a number of people who talk about global health, they say it's because they're not doctors. But if you think about population, I mean, that's true. But if you think about population growth, most of the population is going to grow. The biggest workforce will be in these LMICs in a few years. And so, you know, so I don't believe that we should go there with the intention of almost like because there's nothing there to replace, that's where you should start from. I do believe what provides an opportunity in low, middle, and income countries is this idea of reverse innovation, right? So a few things that we can do better. One is understand how these models work at the edge, right? Because mobile is king in my home in Kenya, you know? And so if your model is going to work, it's going to work on low power devices and in a place that doesn't always have electricity, right? Things that we may not have had the luxury of studying in a more rich context. And then there are also things about like the same context, right? So I'm a foreign doctor, and my parents still walk around with their chest x-rays. They're at home, you know? And so, you know, patient ownership of the record and how, you know, digital, or sometimes people will not want the digital format, even if you have some digital, you know, system, and they still want the printout system because that's the system. So, you know, I think you kind of have to embed yourself in developing. And I know the NIH is actually looking into this, and you're doing quite a bit of this, where you partner with local partners and enable them to build solutions that are specific to them. That's what I would do, because the LMICs are very good at fixing around a problem instead of a hammer looking for a nail.
Mm-hmm.
Well, we're working on a TB algorithm, for example, and most of our data comes from non-TB countries. In order to do that, we need to get data from local data from that, both positive cases, the wide range of TB, as well as negative cases. And so we are directing a particular algorithm for a particular country that has particular needs at TB clinics. So it has to be individualized in order to work effectively.
Well, I think we're getting close to the end. I really, this was a terrific discussion. I think that being able to sort of use again the COVID environment sort of as a catalyst to have some of these important points raised, I think is really helpful. And I hope that all of you found this as helpful as we did. I do want to thank everybody for sharing your experience, Zebra Medical Vision for supporting this webinar today, and really appreciate your attending, asking questions. We're sorry we couldn't get to all the questions. There's so much to talk about today, such a short amount of time. But just as a reminder, today's webinar will be recorded and available on the RSNA YouTube page. And thank you again. It was just a pleasure to be with you all, and appreciate your time and your thoughtful comments.